Hi there and welcome to Felicitas Medica. Today we are going to discuss bronchial asthma, its definition, cellular mechanism, pathophysiology, diagnosis, and treatment. But first we need to know that the lower respiratory tract is composed of trachea, bronchi, bronchioles, and alveoli. So back to bronchial asthma. Bronchial asthma is a chronic inflammatory disorder of the airways, which is the most common chronic inflammatory disorder in childhood. It is characterized by hyperresponsiveness to stimuli and high degree of reversibility, and we will know the meaning of this in a few minutes. It has multifactorial inheritance with genetic and environmental factors coming together to cause it. But what happens exactly in bronchial asthma? Triggers such as pollen, dust mite, or smoke react with antibodies on top of cells called mast cells, a type of immune cells, causing the mast cells to rupture, releasing histamines and leukotrienes. This is known as type 1 hypersensitivity reaction or immunoglobulin E-mediated reaction. Histamine and leukotriene cause bronchoconstriction or constriction of the airway, in addition to irritation by inflammation causing hypersecretion of mucus with mucosal edema by the inflammation and cellular infiltration by eosinophils with cytokines release. This constriction of airways causes areas of hyperinflation causing compression on the nearby alveoli, causing what is called focal atelectasis. This prevents air entry to these alveoli, but the blood supply to them is intact, causing ventilation-perfusion mismatch, which later causes hypoxia, hypercapnia, and acidosis. That's why asthma is important and should be managed urgently. As for the diagnosis of bronchial asthma, we diagnose it by history of wheezes, with coughing of scanty, tenacious mucus, in addition to shortness of breath. They are paroxysmal, coming in attacks. They are worse at night or early morning because of the parasympathetic constricting effect plus stasis during sleep. They are precipitated by a trigger with positive history of atopy such as allergic rhinitis. And by examination we use spirometry or peak expiratory flow meter, which measures the fastest speed for air exit that is weaker than normal in bronchial asthma. We also measure FEV or forced expiratory volume in the first second and the fourth second, and we will detect low FEV1 and higher FEV4 than the normal in bronchial asthma. Finally, the management includes prophylaxis by avoiding triggers, long-term control medications such as inhaled beta or long-acting beta agonists such as salmeterol and formoterol, inhaled steroids, long-acting anticholinergics such as tiotropium, and leukotriene receptor antagonists such as montelukast. As for acute attack management, if drowsy or confused or with silent chest, we prepare for ICU with short-acting beta agonist and oxygen, preparing for intubation. If mild or moderate case, we use short-acting beta agonist with controlled oxygen for saturation, and we may use oral steroids. If severe, we may use IV steroids. So this was bronchial asthma. Thank you for watching, and if you want to learn more about medicine, don't forget to subscribe to Felicitas Medica.